Hello, and a very warm welcome from us here at COVID-19 Updates from Singapore. My name is Claire Cheong, and I'm a third-year medical student at the NUS Business School of Medicine. This is a series of webinars brought to you by the NUS Business School of Medicine, the National University Health System, and the Global Outbreak Alert and Response Network. In this COVID-19 Updates from Singapore weekly webinar series, we will be sharing viewpoints and insights from leading experts in infectious diseases and related specialties and disciplines. To introduce to you tonight's panel of experts, it is my honor to invite our program director, who is also moderator for tonight. Recruited to establish an infectious disease training program in Singapore, he became the first infectious disease head of department at the Communicable Disease Center in 1992. He's also a visiting senior fellow of the Courage Fund at the university. Ladies and gentlemen, Dr. David Allen.
Thank you, Claire. Good evening and welcome to the 9th installment of our webinar series, COVID-19 Updates from Singapore. We hope this broadcast finds you and your loved ones safe and well. We'll follow our customary format this week. Each episode begins with a review of regional and international epidemiology by Dale, an in-depth talk by our visiting guest expert, who is Professor Audrey Chia this evening, a question and answer period with her, followed by updates of current events and what keeps the Director General awake at night by Dale, and then a preview of next week's guest expert. We wish that you will send in your questions via the question and answer tool at the bottom of your Zoom screen, and we welcome your comments of how we can better serve you. If you'd be kind enough to include the country in which you're watching this webinar, we'd be most grateful. At this point, it's my honor to introduce Dale Fisher, who's Professor of Medicine, National University of Singapore, Yang Lulin School of Medicine, Senior Consultant, Division of Infectious Disease, National University Hospital, and Chair of the Global Outbreak Alert and Response Network hosted by World Health Organization. Dale, over to you.
Thanks, David. And good evening, good morning, good day, everybody. Good night, wherever you are in the world. It's always... We're really enjoying doing these. We've heard we're now over 5,000 people generally register, and we're going into 72 different countries. So this is it's pretty pleasing for the efforts that we're putting in. Just going through to the updates of this week, you can see that again I'll compare the last week, so the 28th of May to the 4th of June, and you can see we've gone up around 800,000 or 900,000 cases in that week, and the deaths are still sitting at about 30,000. You'll see Brazil remains firmly now in second place as we all hear it's become the epicenter. So while some countries are, I guess if you like, sitting between the first and the second wave, which most of us feel is somewhat inevitable, it's really a question of what the second wave will look like. Many countries, particularly in South America, are really still in the depths of the first one. So what I'll do is just take you through the regions. This is the customary global epidemiology, and what you can see is the case numbers are going up. This is obviously the case with testing, but the overall numbers are going down. So, sorry, the deaths are going down. So we're looking at around 4,000 deaths a week, whereas before we were looking at more like perhaps 8,000. And this is because I'm sure these case numbers were presumably higher because of low ascertainment. But also, if this was a time of overwhelmed hospitals, we know that mortality increases when hospitals can't cope. You can see each of the regions here expressed. So still the Americas are the major contributor to world numbers. Looking at the Western Pacific WHO region, you can see Singapore and Philippines over the last 24 hours are still the major contributors. You can see the epi curve there. This first hump was the Daegu outbreak in Korea, and since then it's gone along, I guess, relatively flatly if we break down the Western Pacific region. And thanks to the Wipro office for slides like this. Again, you can see Singapore in the blue and Philippines in the green are the main contributors to the shape of the epi curve, with China really petering down to very low numbers. If we look at the Southeast Asian region, in the last 24 hours, we've got about 9,000 cases from India, to 3,000 from Bangladesh. Indonesia has recently declared, I guess, made it clear that there is a low testing rate going on there, and surely low ascertainment, and also probably low ascertainment in numbers as well, numbers of deaths. So you can see Indonesia over here, quite a hectic graph, suggesting a non-uniformity, I guess, of the reporting. Bangladesh, low rates really. India on this sort of scary upward trajectory still. If we look at the European region, again, this is continuing to make its way down, perhaps flattening out over the last week or so, and most of those cases coming from Russia, 8,500 in a day, UK 1,600 per day. Deaths, UK is still getting 300, so this is causing some controversy of how you can still have so many cases and so many deaths, but following the international urgency to come out of lockdown, Russia with about 178 deaths a day, France 100, and Sweden still trundling along at 65. I think they're about over 4,500 deaths now. This is what the epi curves look like for the major contributors. So you can see Russia's lockdown is starting to bear fruit, I guess, with the last couple of weeks relatively flat. UK is still on the incline, and other countries typically on the incline, on the decline. And you can see why places like Germany, Italy, Switzerland particularly can feel a lot more comfortable coming out of their lockdowns. The Eastern Mediterranean is again unique. Everyone's unique. This continuing climb of the number of cases being led by Pakistan with 4,000 a day. Iran, which is now completely open, has 3,000 cases a day. And you can see across the Eastern Mediterranean region, there's really a solid contribution from all countries in terms of seeing numbers escalating. So this is why we get that overall curve for the region, and also the death rates over on this side. This is the country death rates. So you see Iran really did have a biphasic look. So that's one to watch out for, I guess, with all their lockdown. And these low death rates, similar to Singapore with foreign worker dormitory infections in Qatar, Saudi, UAE, Kuwait. This is the Pan-American health region. So the dark yellow is United States, and the pale yellow is Canada and Central America and South America. So not surprising to see where it's going now. United States is still 14,000 cases a day. Brazil 11,000. Peru, Chile, big problems in South America. And you can see these numbers now with Brazil up to 526,000 numbers in total, and we spoke about that last week with a bit more detail. And here's what the epi curves, each predictably sloping up. Africa, likewise, as they ramp up their testing, they're ramping up their cases, but death rates, at least apparently, not too out of control. And South Africa is the leader of in I guess being able to test, but also having the large number of cases. So moving to Singapore, not a lot of news here either. We know the imported case numbers are now rare. The community cases, which are the yellow and green ones, you can see how they have come down. The lockdown, the circuit breaker came about here. These little clusters towards the end are probably more about the extensive testing that's been happening, particularly in the nursing homes and the preschools. And as I say every week, because of the complexities and the various testing strategies, it's not surprising that this graph has this funny shape where it's just continuing to be flat. But we're still optimistic that there is light at the end of the tunnel in this outbreak. And this is the unlinked cases. You can see particularly all of them, I guess, the community ones, under 5, but and a lot of these end up getting linked. But this is why social distancing remains critically important. It's very hard when you've got unlinked cases. Then you can only assume there's under the radar transmission happening, and you can see where it was before. So this is the benefits of the social distancing and why even coming out of lockdown, we don't want all those things, all those measures lost. And the state of play in Singapore now, it's remarkable and everybody's talking about it, but here we are, just 5 COVID cases in intensive care today in the whole country. So it's, I guess we dodged a bullet with all the foreign workers clearly being young enough and healthy and strong enough to not get severe disease. So you can see general wards in the hospitals have really come down over the last 2 weeks from 800 to 300. And this is testimony to all the efforts in building the isolation facilities, because we don't release people back into the community. We keep them isolated until they're no longer a threat. So there's 12,000 in the care facilities, and we've got a lot more capacity than that. So a lot of these isolation facilities are actually half full. So that's a good thing. So I think with that, 24 deaths in total, 36,000 cases altogether. With that, David, I'll hand back to you, and I'm looking forward to hearing Audrey tonight.
Great. Interesting that the second wave in Iran, I don't know that they have a large foreign worker population, but in the first wave, they had a significant mortality. In the second wave, it seems to have been muted. I don't know if that's, again, foreign worker, or if that's the healthcare system adopting or adapting to the situation. Any word from WHO on that?
No, nothing specific on that. They've certainly eased all their measures, and for I think about 2 or 3 weeks now, they've had all the mosques fully operational and things. So no, it could be the lag you often see in mortality. So I guess we'll keep watching.
Okay, thanks so much, Dale. Appreciate it. We'll get back to you later in the episode. I want to remind everybody to send your questions via the question and answer tool at the bottom of your Zoom screen. If you would, please include the country from which you're watching the webinar. We'll get to as many of your questions as possible. And it gives me great pleasure now to introduce our guest expert, Audrey Chia. She is Associate Professor and Director of the Leadership Development Program at National University Singapore Business School. She's a Joint Associate Professor at NUS Yonglulin School of Medicine and Chair of the NUS-wide Master of Science in Environmental Management Program. Her research lies at the intersection of business, medicine, and environment. She'll be examining the COVID-19 pandemic from the perspective of leadership and asks, how have we done? What can we do at present? And how can we prepare for the future? The title of her talk is Leadership, an Intervention for COVID-19 and Beyond. Audrey, we look forward to your talk.
Thank you very much, David. Hello, everyone. I'm terribly excited to be here to have this conversation with you on leadership. Let me just share my screen. So I'm going to be addressing the idea of leadership as a health intervention. And I believe that leadership can be a powerful intervention, not just for the present, but also for what happens after. So here's a preview of what I'm going to be talking about. It's only a 20 or 25-minute talk, so I'm going to be moving really fast, and I look forward to your questions after this. We will start with a quick overview of leadership. I'm sure we are all familiar with leadership. Some of you are leaders. You have experienced the effects of leadership. So I'll be sharing a couple of frameworks that we use in the business school to discuss leadership. Then we will use the lens of leadership to examine the COVID-19 pandemic, the immediate past, the present, and the future. And because we have a very diverse audience here today, people in health and medicine and people from other sectors, my comments are going to be shifting between the two audiences, health and medicine and non-clinical audiences. And I'll try to make sure when this happens, right? So let's begin by thinking about leadership. Actually, leadership is not a mystery. It's something that can be learned, and it consists of a set of behaviors and skills that can be developed over time. The other point I'd like to make is that leadership can be exercised regardless of your formal position, your status, or level. You don't have to be a CEO or a chief medical officer to exercise leadership. And third, leadership does make a difference. Just look at the current pandemic that we're facing now for evidence that leaders can influence the course of the pandemic for better or for worse. So here's a framework that we often use in the business school. This is the Transformational Leadership Framework, and it's the framework for which there is the most evidence. This has been researched for over 40 years and has been found to be applicable across different levels, different industries, and different countries. So this is what we call the 4 I's model. The first I, individual consideration. Who doesn't want to be treated as an individual? So this is where we recognize each person's preferences, strengths, weaknesses, needs, and situation. The second behavior that we look for is intellectual stimulation. To what extent does the leader encourage people to question their assumptions or question his or her own assumptions, or encourage multiple perspectives, imagination, and alternative approaches? The third dimension is something we're very familiar with, and sometimes we talk about it as vision, right? It's inspirational motivation, communicating a sense of mission and purpose to whoever it is that the leader works with. And third, the very best leaders have what we call idealized attributes. They engender trust, they give people a sense of integrity, and there's a sense of fairness about what they do. They act as role models for others. So if the idea of leadership as a health intervention sounds a bit off the wall, I'd like to show you WHO's health systems framework. So what I'm proposing is not really groundbreaking. Leadership has been identified as one of the system building blocks for health systems that can lead to improved health, responsiveness, risk protection, and improved efficiency. So now let's move on to look at the pandemic. And this is the early days. Here's a picture of the toilet rolls and sanitizer, actually from my own home. In the early days, I would say it was a golden moment for leadership. It was a terrible time for the world because we were all experiencing fear, confusion, and anxiety, and there was a lack of knowledge about the virus. We were living in a situation of high uncertainty and trying to retain a sense of control. Hence, there was all the panic buying, right? But this was also a time when leaders were taken very seriously by a public that was hungry for certainty, assurance, and comfort. And so we asked ourselves, thinking back, which leaders do you think did well at the beginning and which ones perhaps not so well? So here are 3 leaders that I think have done well. On the top right, you see the Prime Minister of Singapore. He addressed the nation very early on in the pandemic, wearing a soothing color of pink. He admitted we don't know everything about what's going on, but we need everybody to cooperate. And he gave us an assurance that we'd be taken care of. Just below the picture of Prime Minister Lee is a picture of Chancellor Merkel. Chancellor Merkel made an unprecedented address to the nation, and she very clearly stated that Germany was facing its worst crisis since the Second World War. So both these leaders, both heads of state, did not mince their words. They didn't try to hide. They were very open about the fact that we didn't know what was going on then, right? So they were pretty honest, but at the same time, they assured everyone that they would be taken care of and that perhaps we would have to make some tough sacrifices. On the left, you see Pope Francis. And I was really amazed how the Pope made use of a live broadcast through social media to give a blessing to the world. And this came at a time when people were fearful and were looking for comfort, right? So each of these leaders recognized what people were looking for. They were looking for healing, they were looking for assurance, and actually we were looking for honesty. We didn't want fake news. So while this was a time of golden opportunity for leadership, it was also a time of high exposure and high scrutiny. And it still is, right? It's like sitting for one big, long-drawn public exam where all your marks are shown to the world. Just look at all the charts that Professor Fisher has been showing us. The pandemic has also laid bare the inadequacies of our systems, and it has shown us where our blind spots are. And we're going to talk about that later, right? But in this sort of situation, who has an advantage as a leader? Who has high public trust, is perceived to be a member of a noble profession, and is believed to have knowledge and the solution. So here I'm talking about the healthcare professionals who are listening in. You were portrayed as the last defense and as heroes. But the question arises, are medical and healthcare professionals prepared to lead? Should we expect them to? Do they want to? Aren't they busy? Is it their job? So let's keep these questions in mind as we examine the challenges of leadership. Where is leadership most needed? And this is where we are at the present. We are facing these challenges, as has been pointed out by our experts week after week. It's a chameleon. It's a disease that evolves and has many faces. It's highly infective, and there is early shedding in the community. Now, this opens the door for a different set of leaders that we have seen, right? We have seen the flowering and the blooming of leaders emerging from all sectors of our community to get together to make masks, make their own hand sanitizers, and to attend to people who are perhaps neglected or living alone, right? So this clearly is an example where health and non-health can work together. And the implication for the healthcare sector is really that we should deepen our engagement and communicate clearly with the public and see the community as partners in health. we should also, while the public applauds healthcare workers, also applaud and encourage community efforts. What other challenges are we facing? And these challenges apply to us all, whatever position you're in. Just look at this from the lens of moral intensity, right? When we look at this pandemic, it's not just a medical problem. It poses many moral questions that we need to answer. And over here, we have the 6 dimensions of moral intensity. And you can see that COVID-19 pretty much scores very highly on each of them. Many people are affected. It is close to us. The effects are quickly felt. And there is a concentration of effect on people of certain groups that we're going to look at on the next slide. Probability of effect, quite high. We could get infected, right? And what's the level of agreement among people in society that this is a moral issue? So it's a question we need to answer as a society as well. What are our values and norms, and how do we treat people who are affected by this? Do we send them home? Do we set up isolation centers? And what do we do for these vulnerable groups who suffer disproportionately more during this pandemic, right? And I've listed them all here. There are many. And in each country, we've been finding out that there are certain groups that we seem to have overlooked. In Singapore, it's the migrant workers. Even in New Zealand, which has been praised for doing well, there's been an admission that the indigenous people have been left out. Right. So these are all the moral questions that we face, and there are more. Look at this article that came up in the BMJ, British Medical Journal. Is it wrong to prioritize younger patients? And we come to the question of justice. And in the business school, when we look at justice, we look at these 4 different aspects. The first is distributive justice, who gets what? The second is procedural. How do we make these decisions about who gets what, who gets treated first? There's informational justice. How do we communicate to others, right? And there's interactional justice. How are people treated? Do we treat them with respect? Or are they all treated as just digits and, just more inconvenience, right? So all this points to our need to increase our awareness and capacity to deal with these very complex medical problems that this pandemic and other pandemics as well throw at us, right? We need more debate, more sharing, more debriefing and training to make sense and to handle these questions. There, of course, are other challenges faced by healthcare providers. We all acknowledge that they probably face huge physical and psychological burdens during this period, right? And could face momentum loss and fatigue, right? And so how do we deal with this, right? They've had to go out of their comfort zones. What can we do? I would suggest a high dose of individual consideration, daily encouragement, recognition, sharing successes. This was very evident in the early days of the pandemic, with people sending cupcakes, drinks, ice cream to the healthcare workers. I hope this has not died off. Even among healthcare workers themselves, right? It's great to share success stories, to applaud creativity and initiative by one another, and perhaps even develop a buddy system so that we can take care of each other at work. This also shows that we need training in stakeholder engagement, because when leaders, when doctors, and nurses and healthcare providers are out in the community, they have to lead along with public officials, dormitory operators in the case of Singapore, with foreign patients, with caterers, with non-government organizations. How do we communicate and engage with all these various groups all at one time? Right? Some training in stakeholder engagement would be beneficial. So let's take stock. I think it's clear from all this that role. People's perceptions of leaders are constantly updated, especially during this pandemic. Daily leaders are being socially constructed, and so they are challenged to do well every day. There's so much sense making. There's so much discussion about which leader has done well, which leader hasn't, what ought to be done, and so on. The other point that's really important is that what leaders do or don't do, and whether it's intentional or not, is writ large. People see leaders' actions and decisions as communicating their priorities, their values, and their identity. Just look at the example of religious leaders in Singapore, for example, who have modified the observance of very important religious festivals and services. Just locally, we have had Easter, Hari Raya Puasa, which is the Eid festival, and Vesak Day, which is a Buddhist festival, all under lockdown, and all, with the cooperation of the various religious groups and of course of their religious leaders. So by their actions and decisions, they have shown what's important, and they have tried to create alternatives for people to celebrate these festivals. For leaders, symbolism matters in leadership. A symbolic action, whether it is giving a blessing, as in the case of the Pope, wearing a badge to show your support, putting something up on your profile. All these communicate volumes to people about who you are and what you stand for. Another set of reflections that I have is that it's been really humbling. When we think about the recommendations that are standard in countries like Singapore, Malaysia, China, Europe, and so on, that there are some of these social distancing and lockdown measures that don't really work for other countries, right? So this article in Foreign Policy has highlighted this problem. If you live in a poor country, a lockdown can mean the loss of your income. And anyway, where can you lock down if you don't have a home or if you don't have adequate shelter, right? So we need to recognize that there's always a trade-off. The solutions or the recommendations that we give are not cost-free, and they themselves carry their own risks. Over here also, I would say there's a high need for individual consideration, thinking about the circumstances that each individual or each group faces. And there's a need for intellectual stimulation for us to think, what else could we do in certain circumstances where these standard recommendations don't work? Even with testing, there are challenges of geography and reach. It's fine if you live in a city, but how do you get test kits out to the last mile, to the remote and rural areas, to people who might need them? Well, all is not lost. As we have seen, and as Dale has pointed out, some less wealthy countries have managed well. Clearly not one size fits all. And in my own work on social entrepreneurship, I've observed how social entrepreneurs come up with affordable and yet effective innovations and solutions to health problems in resource-poor environments. So it's really worth a look to see what social entrepreneurs have done during this pandemic. And we also noticed that in countries that are less well off, there's a huge pool of community health workers. These are not professionally trained, but they are out there in the community and they help to give out health messages and to safeguard the health of the community. So all these are frugal solutions that are worth learning from. So this takes us to the last part of my presentation, which is what can we do beyond COVID-19? How can we prepare for the future? First observation I have is that we should lead by educating. The pandemic has shown us that health and scientific literacy are not that high among the public. People still do not understand what PCR tests are. I've received many questions about false positives and false negatives. And I've also noticed that people tend to confuse viruses with bacteria, right? And there's also been this practice of spraying disinfectant on people, which Professor Fisher has pointed out is perhaps not the best thing, right? So here's a chance, while the public is very interested in health, to engage and educate and actually increase health literacy among the populations and work with others to get the message out. Here's a picture of the TikTok hand wash video from Vietnam. We should also lead together, because as the pandemic has shown us, there are many resources in the community. Right now, it's a good time to develop healthcare allies, to build social connections, to build bridges to all these groups that could help us. So think about how we can align interests with other groups that perhaps have a connection to health. For example, environmental groups, as COVID-19 has shown us the connection between environment and health. And there seems to be a perception that if we have a vaccine, everything will be fine. Is that really true? Well, as leaders, I think we should consider the entire value chain. Where could it break? Maybe it won't be effective. And even if there's a vaccine, will it be affordable, available? Will people have access to it? And then, of course, we need to deal with resistance among anti-vaxxers. So I would say vaccine is not a silver bullet. And finally, I think we should think about leadership in health and medical education. What do we want in our future healthcare professionals, right? Has this pandemic shown that perhaps we should look into our selection criteria and our curriculum to prepare them? And what about current practitioners? Should leadership be part of continuing professional education? So the bottom line, I think, is that we should invest in leadership. Leadership underpins our pandemic preparedness and our responses. It enables us to implement our plans that much better. And COVID-19 has shown that we can and we need to cultivate leadership at all levels. So let's strengthen our foundations so that we'll be ready for the next challenge. Thank you. Over to you, David.
Thank you very much, Audrey, for that thoughtful examination of leadership and how it applies in the era of COVID-19.
Thank you.
We've got many excellent questions, and thank you so much for taking our questions. Claire, do you have a question for us?
Thanks, Dr. Allen. Prof Chia, we have many great questions from the audience.
Oh, goodness.
One of them is,
Right.
You touched on whether doctors are expected to be good leaders during your talk, but could you please comment on whether the skills required to be a good clinician are different from those required to be a good leader?
Sure, be happy to talk about that. I think to be a good clinician, you would need a great deal of empathy. You'd need to have a good listening ear. So all these actually work into individual consideration, right? I think in medical education, it's emphasized, how we communicate with our patients. The thing is, I think we need to broaden, for example, some of these communication skills. When we're talking, when a clinician talks to a patient, clinician seems to know more and also to, have the solution. But when we communicate with stakeholders during a pandemic, we may not actually hold the solution, right? We need to listen. So I think some of the skills would be different. There are other skills. For example, look at how doctors seem to have been sidelined in some countries. Leaders don't want to listen to those doctors anymore. So this thing about, how do you get heard and how do you get your voice out? I think that would be something worth learning as well.
What defines good leadership in a pandemic or a similar crisis?
Yeah, I think we have talked about it a bit earlier. In the early stage, right, people need comfort, they need assurance that they'd be taken care of. In the middle, that's when we want to show that we have made good decisions. We have considered the data and we've listened to people, right? So it's a time for action. And I think this is where perhaps, you start to see the difference across countries, how some others have responded much more slowly, even though they had the data, and some others did not, right? So the thing about leading in a pandemic, it's a mix of decisiveness as well as of compassion and a listening ear, right? So we need to listen, we need to engage, but we also need to act. We cannot suffer from analysis paralysis, right? Sometimes we analyze too much. There's so much information coming out. We need to make a decision. The other thing the pandemic has taught us is that leaders need to look far and wide. In many countries, as I pointed out, we have left out groups of people. We've taken for granted. And perhaps we also need to listen, right? On one of my last slides, I had this thing about installing canaries. We need to listen to the contrary point of view and to people who tell us, hey, there's something wrong here and you need to pay attention, right? And sometimes we don't want to hear this bad news, yeah? So in Singapore, for example, when the first migrant worker fell ill, some NGOs said, oh, well, this is going to be terrible if it affects the dorms, right? So we need that kind of a listening ear. We need to pay attention to people who tell us perhaps news that we might not want to hear, but they are the people who are in the community. And as I said, we need to have healthcare allies. We need to bring them in and to listen to them, especially in a pandemic.
We've got a really interesting question next. It's, could you comment on why countries with women leaders seem to have done better at managing the COVID-19 pandemic? Examples would be Germany and New Zealand.
Okay, yeah, I think that's a really cute question. And I think it's also the result of cherry picking, right? If we really want to study the effect of women leaders, I mean, as a woman myself, I really like it to be true. But just look at Belgium, right? Belgium has a female head of state. It's not done so well. And we also have countries where there are male leaders, right? Like in Vietnam, which have done well, right? So I think this observation about women leaders is also a result of cherry picking by the media and also by others who like to focus on certain leaders who are perceived as, more attractive or more charismatic. Yeah, so I actually don't agree with that, that assertion. I think we need a more systematic study.
Very fair. Okay, so the next one is, how should we respond when top and high-ranking officials in one's countries are the ones who are not abiding with the rules pertaining to this pandemic, like lockdown protocols and social distancing?
Oh yeah, yeah. This is what we mean by symbolic action, right? We can go out and tell everybody, that they should wear masks, but then we don't have to. Or that they should all stay at home, but then we can go out, right? And I think how they've been dealt with, for example, by the media, by other people, is actually deserving, right? Because probably they have already been persuaded by their advisors, by doctors and so on, not to do this. And yet it seems to be a deliberate flouting of best practices. So this is where the fourth eye, role modeling, idealized attributes, I think is largely missing. And we have to call that out. Yeah.
Thank you, Prof. Chia. So the last question I have is, are there differences between Asian and Western models of leadership?
Oh my. Okay, this is another one of those really big questions, like about, women, Asians, just look at Asia. How many countries are in Asia? Look at the vast geographical expanse, right? So there again, there's this temptation to cherry pick, right? But it's so difficult. Even I myself, I'm afraid to venture into that, and you talk about Asian and non-Asian. Goodness, non-Asian is the rest of the world outside of Asia. Yeah, so I know people have said that, wow, during this pandemic, look at all those Asians, they're so good, and so law-abiding and compliant, they all stay at home, right? And that's how we've been portrayed, right? There is a difference, I would say, in terms of the values, right? So leaders don't operate in a vacuum. And we know that in different countries, there's different emphasis on individual freedom, on social solidarity, and so on. And I think that's what makes the difference. That perhaps if you set the tone, right, you could expect a higher degree of compliance in some Asian countries where there's a huge emphasis on social solidarity and collective, the greater good. Yeah. Thanks, Wes.
I'm going to jump in here, Claire, and take my moderator prerogative and ask a question for Audrey. Audrey, can anyone be a leader? If anyone can be a leader, how can society avoid a misguided leader who appears to provide certainty, assurance, knowledge, and comfort from leading us astray for their own purposes?
That's a great question, right? And we have seen so many pretenders, right? These are the ones that you're talking about. I think, okay, so let's get back to your first question. Can anyone be a leader, right? So I think we can all, so there's a difference between being a leader, holding that position, and showing leadership behaviors, right? So even, a cleaner could be a leader. You don't have to be a high-ranking official to be one, right? So that's an important point. The other thing is, if anyone can be a leader and this person ends up leading people astray, right? That's society, isn't it? There will be checks and balances. And I think that's why it's important for people to be aware, what leaders are expected to do, looking at these leadership frameworks, how do they hold up, right? We need to hold them accountable. And we also need to build checks and balances into our organizations and our countries, right? Leaders should not be left to lead on their own. If anything, the pandemic has shown us that we need to lead together. We need to lead alongside with other people. And we need to speak frankly and openly to one another. And if we do that, right, and we have systems that hold leaders accountable, then it'd be much less likely for these occurrences to happen.
Okay, Prof Chia, thank you. We've got a couple more questions in from the audience. Here's a slightly difficult one. Can a crisis leader be successful if he or she has poor personal character? Are there examples, and do these examples rise above their flaws or actually use them to their advantage?
Okay. So this is an interesting line of research in leadership, right? And the main question we need to ask is, how central is this flaw to what the leader has to do and to the role that the leader holds? If it's peripheral, maybe it's not as great a problem. But if it's directly interferes with what the leader is expected to do, then of course it would pose a problem. So I think what this question is trying to get at is perhaps it's a veiled question asking about certain leaders who are highly narcissistic and egotistical and so on. In that case, yes, it gets in the way, and we don't have to name names because there are many around, right? But as for flaws that are a little bit more distant from the practice of leadership, right? Then let me think. What kind of flaws would these be, right? Perhaps that somebody is a compulsive eater, then that perhaps can be kept aside from the performance of leadership, right? So I don't know whether I've really answered that question because it seems a little bit and vague. Claire, do you have an idea what else it could have meant?
Sorry, I'm not very sure, but maybe the audience member can send in the question again. But this next question is a bit related. It's from someone called Harsh Tanurka in the US. He asked Prof Chia if you could share your thoughts on responsible leadership.
Huge topic. And I think responsible leadership really starts with asking ourselves who we are responsible to, right? To whom are we accountable? And I think the pandemic has shown us that, the sphere of accountability of leaders can be very broad. In this pandemic, whether you're looking at national leaders or healthcare leaders, right? There's a whole spectrum of people to whom these leaders are accountable. because it's a public health threat, right? To be responsible means, for example, to be communicating with them, keeping them informed, apologizing perhaps when you've made a mistake. And it's quite possible at this time. Sometimes our assumptions are wrong, the knowledge is evolving. It's okay to say that, oh, you know, we've forgotten about this, we've omitted that, but we'll make good on it, right? We will try to make up for it. And I think that's what is at the heart of responsible leadership. It's really about being, you know, recognizing who you're accountable to and being honest about it and keeping them informed as you go along.
Okay, thank you, Prof Chia, for
Thank you.
the concise summary of what that entails. We've got 2 more questions, I think. The first one is on social entrepreneurship and its role in the pandemic. So I guess since this is your area of research, could you share with us some examples you find that are notable?
Yeah, I could go on for 10 hours. Yeah. So it's really amazing because social entrepreneurs work in a whole spectrum of areas, right? So they could be working, for example, in access to clean water. And that's so important at this time when we're asking everybody to wash their hands, right? You know, it's something that we take for granted. Yeah. Or they could be working in telehealth, right? Of course, I know under lockdown, even, you know, developed countries like Singapore are using telehealth. But in many other countries where their populations far out, whether it's rural India or in Africa, right? Telehealth is the mainstay. So at these times, especially when we want to feel connected to some medical attention, telehealth is vital, right? So those are the people who really work, you know, very closely in relation to medical and health services. There are others as well. So I know Copernic, which is you know, run by some fantastic social entrepreneurs in Indonesia, has come up with low-cost face shields, right, for health workers. So the whole idea is, you know, they try to solve a problem, but they also try to solve it with a very low cost. And it's something that we could really learn from, because we keep complaining that the cost of healthcare is so high, right? And social entrepreneurs take care of the social determinants of health. They also look at things like, you know, mental health and well-being, right? So in my own research, looking at leading social entrepreneurs all over the world, this is a key area, right? And it's been highlighted in the pandemic that we all suffer mental health damage, right? You know, because of being at home for so long, being cooped up, being away from our friends and so on. So now it's really a good time to shine a light on the whole range of benefits that these social entrepreneurs have been working towards. It's not to say they're perfect, right? They are entrepreneurs. Some of them will fail. That's in the nature of entrepreneurship. But I think frugal as well as simple solutions, especially for the people who are left out, who are at the last mile, who are poor, who cannot afford the regular services, is what makes them really exciting. Thanks for the question.
Thank you. It's really lovely hearing about the least, the last, and the lost. Dr. Allen, did you want to move on with the program?
I think we're out of time for questions, Claire.
Right.
Thanks so much.
You.
Thanks, Prof Chia. We're going to move now to Dale providing us a weekly update. Over to you, Dale.
Yeah, so talking points this week. I've just got a few. One being about we can travel again, the Wuhan labs, Ebola, and images from the US. So I was excited when I heard, firstly, there's going to be a sort of a travel hub established between some countries out in this direction. So what that looks like, we're not quite sure yet, but the pathway to China is going to be first. And I was actually thinking this will be a great time to get a holiday, because no one's had a holiday for a long time. There's hardly any COVID in China, and there'll be no tourists. So I was thinking seriously about it until this came out in the paper. I think this morning. So you have to have a sponsor to go, and you'll have to stay with that person. He or she will have to apply for you, and you'll have to stay with that person. You need to get a visa if you normally need to get a visa, and you're only allowed to go to those. If you're coming to Singapore, you have to have been in those 6 regions that I mentioned on the previous slide. You'll have to have a swab within 48 hours of departure. On landing, there'll have to be another swab, and China will also request some serology, and then you'll have to stay in a hotel for a couple of days until the results come back. Those who are cleared follow a controlled itinerary for the first 14 days, so that it's clear where you are and you can be contacted if you need to be. You can't use public transport, buses or trains during the period, and people coming from China will have to put the Trace Together app on. So I thought there goes the holiday, David, but nonetheless, it's nice to see some efforts being made in this, but this is really for I guess the businessman that's going to be there for quite a while. So you remember a couple of weeks ago I mentioned that Wuhan had found some asymptomatic cases, and I really did wonder whether it was possible that they could do 10 or 11 million swabs, but they did. They did 9.9 million over 10 days. They ramped their labs up. They had 23 labs. They ramped that up to 63 labs. They found 300 completely asymptomatic people. And this was done through largely through pooled testing, which a lot of us are doing in a lot of the settings are having in Singapore. This is where you actually put 5 swabs in the same transport medium and test them all together. And this saves you a lot on reagents and time. Of course, if it's positive, you have to go back and do those 5 people again. But if it's but in a low prevalence setting, this does well. So what they did was they got community workers to go door to door, knocking on everybody's apartment or house door. They told them the time and the place where they had to be. The queue was about 15 minutes long, so it was a very well regimented thing. All the positive cases. Then they did environmental sampling, including toothbrushes, phones, door handles, and elevator buttons, and they were all negative. So this whole argument over asymptomatic cases, do they spread? This Wuhan is good evidence that actually asymptomatic people that stay asymptomatic have a very low infectivity. So I do recall saying we're going to learn a lot from this exercise, and I think we are, but amazing stuff. You've probably all heard the spectre that Ebola is back. It actually hasn't gone away. We know we get pardon me. We know we get outbreaks every couple of years. This is actually in Bandaka. So this is DRC in Africa, the Democratic Republic of Congo. This is Bandaka. The other side is North Kivu. So it's not the same outbreak that we've just had, where there's been, I think, 3,900 cases so far. The outbreak in North Kivu has been 37 days, I think, now without a case. So they'll declare that outbreak over in 21 days. And but of course, as that one's over, we've got a new one starting here. But this area is used to having Ebola outbreaks. They had one in 2018. In fact, this same institution, they had, I think, 50-something cases that time in 2018. And in fact, the whole of DRC, these are the places that have had outbreaks. So as we know, this normally comes from ingestion of non-human primate meat, so monkey hunters or blood products from monkeys infecting people. And as in this outbreak in Bandaka, it's recognized in a hospital because that's where the cases get amplified. So just a little aside, something non-COVID for a change. Just to go back, yeah, this is the outbreak that's just finishing, and this is Bandaka. So you can see there's really no link between the two. And my last one is just, I couldn't go past this week without some images from the US. Really, if you wanted to have a very successful second wave, this is what you'd do. And it's terribly sad. I'm sure everyone gets quite distressed when they look at a lot of these these images, and they're really mass gatherings by any way you look at it, and I think we're going to see the ramifications of that over the next couple of weeks or month. But actually, the images I really prefer to see is this, which is really quite tear-jerking. Actually, when you see the I guess the battle between the two sides with the population versus the police, and then when the police drop to one knee, you start to realise that this is a time when people can come together. So that's my touching final slide for tonight, David.
Thank you, Dale. These are troubling times in many ways. It leads me to thank both of our speakers for an engaging evening. We very much are grateful for your contributions. And to preview next week, our speaker will be Andrew Rose. He's Distinguished Professor and Dean, National University Singapore Business School. The title of his talk will be The Economy After COVID-19. There is a chat box tool at the bottom of your screen. We would appreciate your feedback. This chat box will be open in another 10 minutes or so. We do want you to provide your comments. Until next week, stay safe and wash your hands. And for those of you who are frustrated by the pace of reopening from the circuit breaker, let Fleetwood Mac's 1972 song, Don't Stop Thinking About Tomorrow, be your guide. Good night.